So first, I have to say thank you to Jason for the kind invitation. This has really been an honor for me. I don't really visualize myself as somebody who comes and gives grand rounds at Stanford. Although I will say I do have a patent on a device that helps to take out endografts when you have to take them off they're infected. So maybe it's not too far, but the amount of just intelligent, thoughtful research and work going on in this department is really inspiring, and I'm just really honored to be considered for this. In addition, to be invited for this lecture in honor of Weesam Al-Khatib, who I did not know. But in talking to Jason and talking to his family and reading a bit online, I'm just really inspired and impressed that his family was able to take an event that had to be really, really painful and difficult to deal with and turn it into something with a lasting positive impact. And I think if we can all do a little bit of that in our lives, it would be great. He was a university and VA vascular surgeon, and I also am a university and VA vascular surgeon, very dedicated to teaching medical students and residents, and that's clearly been my passion and my focus in my work. And he was obviously well loved by his patients, students, and colleagues. And it's not for me to say whether I'm well loved or not, but I certainly have had an impact. And his legacy really is in the excellence in education and patient care, and I think that's something that we all need to value. And so I'm truly honored to be here. So my only disclosure is that the opinions given in this talk are really mine alone. They're not the opinions of any organization with which I'm affiliated. And there's many of those organizations, so I need to be very clear. These are just my ideas. I'm going to lay out the current landscape in surgery as I see it. I'm going to discuss the increasing complexity and volume of our work and outline the workforce issues, discussing the prevalence and risk factors for burnout, and then suggesting solutions, hopefully, both personal and systemic for burnout, recruitment and retention of surgeons, which is critical, as you'll see as I go through this. I also need to welcome the Wisconsin Surgical Club and say thank you for not being too disappointed in having to listen to me talk. You come all the way this way just to hear a native daughter give a talk, and I feel a little bit embarrassed about it, but grateful that you're here. And some of you have heard a version of this talk, so please don't be too critical at the end. So, I just feel like I started thinking about what to do with this talk, and I started thinking, I really do feel like our work is getting harder. I feel like what we do every day is just getting more and more challenging, more complex. And the truth is the population is aging. According to the US Census Bureau, by 2030, 82 million people in the United States will be over 65, and by 2040, it'll be 88 million people. And the population of over 65 people will increase until at least 2050, which means that there'll be more patients with disease and more frailty, which seems to be associated with surgical complications. There will also be more surgical volume as the amount of volume of surgery is higher in the later stages of life most of the time, and more complexity. We know there's a high disease prevalence in the older population. Over 80% of people over the age of 65 have at least one chronic condition, and almost 70% have two. And most of these conditions are things that lead to at least vascular disease. I view this from a lens of vascular disease, but they lead to needing all types of surgery. On top of that, we have a high prevalence and rising prevalence of obesity. This is obesity tables from 1955 to 2000. And the people over 65 to 74 are in purple, and that's rising pretty quickly. And then if you look from 2000 to 2018, the trend continues with really half of the population being either obese or obese, which of course adds complexity to whatever it is we do. 40% of people older than 60 are obese, and the greater obesity, comorbidities, and age leads to higher complexity and complications. So this, for those of you who've been around a while, this idea that things are harder, sometimes I get called in the middle of the night and I look at a patient and I think, how on earth am I supposed to be successful at this? How am I going to pull success out of this situation? It's just, that feeling is valid, I think. In addition, the volumes of what we do are increasing. This was a study published in 2003 looking at the forecasted increase in work. As you see on the table on the left there, the majority of the work increases were happening in people over 65. And this has mostly come true when I look back at the MGMA median RVU targets for vascular surgery. Those were the ones I had access to as vascular surgeon. They've increased by 55% since 2000. So my RVU targets have gone up quite a bit since I started on faculty in the year 2000. So then what's happening with how we're getting paid? What's happening with reimbursement? This is a fairly depressing chart to see. So this is the inflation adjusted Medicare payment. It ends in 2019, but it's not getting higher, I can say that. So the payment to hospitals and skilled nursing facilities have at least stayed stable, if not increased a little bit, but physician payment has gone down. And so the struggle of reimbursement is real, and as costs go up, it becomes harder and harder to cover overhead. There's multiple factors covering this. So at the end of 2023, this was the picture we were dealing with. We were dealing with a proposed overall decrease of 8.47%. And I'm not an expert in reimbursement, but a big piece of this came from a conversion factor due to E&M coding changes to redistributed payments from procedural codes to E&M codes. And then there was a 4% decrease triggered by the pay-as-you-go sequester, which was basically meant to ensure that federal spending didn't add to the deficit, so that if federal spending went up, payments had to decrease. The end of the year omnibus bill helped this, so they passed an end of the year bill to help this. It didn't completely eliminate the cuts, so we still got a cut. It just wasn't 8%. About a 2% decrease took effect January 1st on the conversion factor cuts, and they delayed but didn't eliminate the sequester. They basically paid for this by extending the current sequester until 2032. So they kicked the can down the road again, which is really not all that surprising. That seems to be kind of how that gets handled. In addition, we have an aging of our surgical workforce, at least in general surgery and in vascular surgery. 47% of general surgeons are over the age of 55, 42% of vascular surgeons over the age of 55. When you compare that to other things like critical care medicine, emergency medicine, interventional radiology, interventional cardiology, once again, as a vascular surgeon, when I look through the lens, who else does my work? It's the interventional radiologists and interventional cardiologists, and they're pretty young as a specialty. This was a study that was published in 2013, and it goes out to 2025, looking at the expected demand in full-time equivalent positions in certain specialties. And this is, for the most part, come true. I mean, we're in 2023 now, so you can pretty much say how have they been at predicting, and it's been pretty accurate, to be honest, that we really have had to increase our workforce, and there's a lot of jobs open, at least in the vascular field. Going into the future, this was published a few years back in 2022, or actually a year ago, by some of the people at Ohio State. They took the AMA master file and they looked at from I think it's the last 20 years, and they looked at the growth of the specialty, and they sort of predicted the continued growth. And then they looked at the projected needed work, and they looked at who was going to be short. And if you look at the table on the upper right, by 2030, there's 9 specialties that will be short, which include vascular surgery. But look at general surgery. There's going to be a huge need for an increase in general surgeons, that if we don't do something different to recruit and retain general surgeons, we're going to have a lot of people who are falling short on care. Now, some of this, of course, can be handled by the increased physician extenders and maybe some increased efficiency in care and things like that. But I think we are in a challenging situation of having to really try to attract the best and brightest to our field. And so we have to sort of find a way to kind of combat all of these pressures and really allow us to have a good culture that really recruits people, makes them want to be surgeons. The vascular surgeons are maybe a little bit lucky. By 2050, we are projected to be okay. And that's probably because the aging population, the baby boomers will have most likely, passed at that time, and there won't be as many older people. And perhaps, hopefully, maybe people are a little healthier and the incidence of vascular disease will go down. I don't know. So the change in RVU production needed to sort of handle this shortage is fairly staggering for most specialties. So if you look at general surgery, the workload changed by 2050, 62%. So you're already working hard, and now you're supposed to add another 62% onto your current productivity. We're going to have to figure out a way to make that happen. We already work long hours, so this is somewhat old data. It'd be interesting to see this done over again, but you know, the surgical specialties are all at the top. And this is in comparison to family practice, which you can argue whether that's a valid comparison or not, but the hours that we work are long. And you know, we enjoy our work, and that's okay, but these are the challenges we're working with. And so I shudder to think that I'm going to talk about burnout at Stanford, where you guys have Kate Shanafield, and you know, I'm sure you guys all have heard all of this over again, and I'm not going to focus a ton on it, but I am going to go through a few things. So we know that as work hours rise, so does burnout. And we know that burnout is an issue in healthcare. And thankfully, it's been recognized. For a long time, people sort of poo-pooed it, but it has been recognized as a problem. And you may not want to call it burnout. You may want to call it wellness. You may want to call it something else. But the thing is, we do have to pay attention to how it is we feel at work, how we do our work, and how satisfied we are at work. Burnout ramifications are hard. 40 to 50% of physicians report burnout, and the ramifications include increased errors, decreased productivity, and turnover. And then the ramifications to the surgeons themselves and the physicians themselves and the providers themselves are depression, substance abuse, and even suicide, which is really scary. So this is one of the first papers looked at prevalence and burnout in surgeons, and it's fairly alarming. It's a little old now, but you know, 40 to 50% of surgeons really met the qualifications for burnout. About mostly 20 to 30% had depression, a positive depression screen, and low mental quality of life. About a third said they wouldn't become a surgeon again, which is not great. And then about half said they wouldn't recommend their children to be surgeons. So I think that becomes difficult to recruit when the surgeons aren't telling their children to be surgeons. The key drivers of physician distress have been well described, including excessive workload, inefficient work environment, problems with work-life balance, which I don't love that term, but that's how a lot of people say it, some loss of autonomy and loss of meaningful work. With the meaningful work, you know, when you're in medical school, you sign up to really have quality face-to-face time with patients. You have pride and satisfaction in your work. You have that relationship with patients. As a vascular surgeon, that's why I chose vascular surgery. I wanted that longitudinal relationship with patients. I wanted that sort of primary care relationship, but I wanted to be a surgeon. And it's been kind of replaced by increased record keeping, regulatory compliance, et cetera, leading to. So I was lucky enough at the SBS to be involved in the wellness task force, and we did a survey looking at burnout in vascular surgeons, and we wanted to define the prevalence and talk about things that we might be able to do to help with it. We surveyed the active members, and basically we had a 33% response rate, and the demographics, the mean age was 50, and the years in practice 15. The majority were male, as the majority of our members are, and 84% were married. 41% met the criteria for burnout, and the factors that were associated with it were age, work-related pain, which is very interesting, and I'll talk a little bit more about it, and then conflict between personal work and personal life. 36% endorsed symptoms of depression in the past month, and this was associated with not having enough family time, again, work-related pain, conflict between work and personal life. So a fairly high rate of burnout of 41%, and advancing age, physical pain, and work-life conflict were independent predictors for burnout. So I was able to take this analysis one step further and look at, is this different between men and women, which is something that is really important to know, because we don't always react to situations in the same way, and our social constructs are different. And so we stratified the results by gender and did logistic regression, and we did have a higher percentage of women responding to the survey compared to the SBS membership, so slightly overrepresented for women. The women respondents were significantly younger, and that's just the demographics of our profession, and they had fewer years in practice. The prevalence of burnout was the same between men and women, so it really wasn't different in terms of the overall prevalence. Suicidal ideation, however, completely different story. Much higher in women, which was alarming, really, 12.9% versus 6.6%. So high rate of suicidal ideation. There was a higher work-life balance, conflict, self-reported for women than men, although men had, it was a fairly high rate in men as well. Women spent more time working at home on the EMR, but the men were more likely to be dissatisfied with the EMR, and that may have been an age-related thing. The predictors of burnout stratified by gender. So not enough family time, having not enough family time was overall a predictor for burnout. For both men and women, it seemed to be a stronger relationship for women. Worst work-related pain was also a factor in both. And then EMR satisfaction seemed to be more important to men. The predictors of suicidal ideation was more common in women, and then work-related pain was a risk factor for both. And so, once again, vascular surgeons sitting in the operating room, wearing lead, wearing loops, bent over all day long. Ergonomically, it's a challenging environment, and having pain can lead you to have all sorts of consequences. So we have to learn how to take care of ourselves. So our conclusion was that we had a high prevalence of burnout. There were some gender-related differences driving career dissatisfaction. We were really alarmed at the rate of suicidal ideation amongst women, and I'll talk a little bit more of that in a minute. And then work-related pain is a significant factor for both men and women, and programs that help mitigate that really would be helpful for all vascular surgeons. This is another study done. Actually, I was in residency with Michelle Brownstein and Betsy Tuttle, the senior authors on this paper. But they looked at 3,800 surgeons and found similar things. More women, fewer women reported career satisfaction. More women felt that it encroached on personal time in a problematic way. And more women reported primary responsibility for meal preparation and cleaning. And in their multivariate analysis, they found that the responsibility for at least one chore at home associated with lower satisfaction for women. Their increasing age had higher satisfaction. So the older you got in your career, it was they were more satisfied. And insufficient time for family was bad for both men and women. Higher degree of collegial support and work-life balance. And I think the collegial support of work-life balance had the strongest association with high career satisfaction for both men and women. It was a stronger association for women than men, but it was important to both. And so this collegial support is something that I think is really important. And Jason and I have talked about it. I say this publicly all the time. I have the best partners on the planet. Actually, one of my partners is in the audience today. I mean, I have the best, two of them. Okay, Mona, I know Joe, you count, but Mona's my vein person, and she really helped me out in the vein clinic. So I always think of her first, but I have great partners. I have great partners. So it's so important to your longevity, to your satisfaction at work, to have people that have your back, to really have people who will support you. I'm here basically for a whole week. I'm here at Stanford, and then I'm going up to Seattle, and there's somebody at home taking call. And I have to go back and pay that back and help somebody else in their career and help give them opportunities. So you need to feel supported in your work for this to work. What about the residents? So this was the survey that was done after the 2018 ABSITE, 7,000, and you may argue that's a horrible time to ask residents about burnout, and it probably is. But 7,400 surgery residents, weekly burnout 38%. So very similar to what's in the practicing surgeons data. Suicidal thoughts, 4.5% in the last year. Now, here's the interesting part to me. The mistreatment, which was defined as harassment, discrimination, and abuse. Harassment, so self-reported harassment, discrimination, abuse was associated with a higher risk of burnout. And the women were more likely to experience mistreatment. Now, men experienced it too, but women experienced it, or at least self-reported it at a higher rate. And I wonder if that's why the women vascular surgeons had a higher rate of suicidal ideation. I just wonder if we didn't think to ask them that on our survey, so there's no way I can confirm that hypothesis, but I do wonder if that's part of what's driving the higher suicidal ideation rate in women. So here's what we have. We have high work hours, we have workforce shortages, we have threats of decreasing compensation and increasing administrative burdens, which lead to prevalence of burnout and suicidal ideation, and an ongoing workforce shortage that we have to recruit and retain trainees. So what do we do? Like, how do we handle this? What do we do going forward? Well, I think there's both personal and systematic solutions, and I want to discuss hopefully some practical things that you can do personally, but also some things that I recommend on the system side to help us with this. As I say, you're not required to set yourself on fire to keep other people warm. I love this quote because I think people sometimes have the tendency to do that. And we have to normalize taking care of yourself. We have to make it okay to take care of yourself. And we have to actually make it okay, we have to make it not okay not to take care of yourself. And we're doing that. And honestly, I feel like in our departments of surgery, we are, this culture change is happening. So what can we do to take care of ourselves? We can sleep. We can sleep. One of the things is sleep. So sleep deprivation is associated with burnout. That's been confirmed in multiple observational studies. This review in Chest in 2019. So interestingly, it's in Chest, right? Like this is a journal, and they're talking about burnout and sleep. The hypothesis is that it's due to either chronic energy depletion or activation of the hypothalamic pituitary adrenal axis and increased bodily stress that causes some of the factors associated with burnout. So this is a book that I don't know how I came on this book, but it's actually a very interesting book. It's written for the layperson, and so it's an easy read. 2/3 of adults fail to get 8 hours of sleep per night. Okay, and decreasing sleep efficiency causes increased mortality, decreased physical health, increased depression, decreased energy, and increased forgetfulness. So it's all associated with this. Some of the experiments that he talks about in this book are interesting and somewhat alarming. For example, there was a study that they did with people, young, healthy volunteers. If they got less than 6 hours of sleep for the week before they got the flu shot, they had more than 50% reduction in their immune response to the flu shot as compared to those who got more than 7 hours of sleep during that week before the flu shot. So that's a pretty dramatic decrease in your immune function. And it sort of explains why when you were in college and you had finals week and then you got the week off after that and then you were sick that whole week after finals week, at least I was, at least made sense to me. So the physical effects of less than 6 hours of sleep routinely: decreased immune function, doubles your risk of cancer, increases risk of Alzheimer's, disrupt blood sugar levels, all of these things that you can see here. So in addition, there's cognitive effects. These are really, these are fairly causal because they're done in a laboratory environment. The cognitive effects decrease, lack of sleep decreases your ability to learn and memorize, make logical decisions, and retain newly learned motor skills. So this was something that was published in 2021, and I found it really interesting. This was, they were doing a randomized controlled trial for a drug that's supposed to help clear amyloid to help prevent Alzheimer's. Okay, so in screening people to get them into the trial, they had to do a PET scan and they had to answer a questionnaire. And when they looked at it, people who self-reported sleep less than 6 hours, routinely less than 6 hours, had more amyloid on their initial PET scan. So when you look at that table there, if they had less than 5 hours, that was the highest amount of amyloid. 8 hours was the best, and 9 or more actually had a higher amyloid. So we can't say it's causal. We can say it's an association, but it's fairly interesting. So how do we do it? We're surgeons. We have to take call. We have to take care of patients at night. We have to do something, right? I do find it interesting that there's a quote, there's a Irish proverb that says a good laugh and a long sleep are the best cures in the doctor book. So somewhere along the line, people have figured out sleep is restorative, right? We need to prioritize sleep. We need to understand it creates strength. When I was in training, it was like, sleep when you're dead, right? Like you don't have to sleep, right? Well, but you do have to sleep. And you have to prepare for it and plan for it. I was actually talking to Jason this morning. He said, "How did you sleep?" I said, "I really didn't sleep very well last night." But normally I do. And normally I plan for 8 hours of sleep. I go to bed early. I go to bed by 9 o'clock. And I realize it makes me old. I'm old. Okay. I'm okay with that. But I go to bed by 9 o'clock and I'm up at 5 o'clock, and that's 8 hours. And I've got my window. Do I always sleep those 8 hours? No, but at least I've given myself the opportunity. Now, of course, when you're on call, that interrupts it. How do you ensure that when you go to bed, you can actually sleep? I'm horrible at doing all of these things, so I'm not trying to stand up as a great role model, but this is what you should do. Decrease your caffeine, limit your LED light exposure, avoid rigorous exercise. That one I do. I avoid rigorous exercise all the time, but you should avoid it before you sleep. And avoiding alcohol, because it does disrupt. There's no amount of alcohol that doesn't disrupt your sleep patterns. But the main thing is to set aside enough time. So how do we do that as practicing surgeons? So this isn't going to be the solution for everybody. I think some specialties have done it better than others. I think some specialties workload is more amenable to doing having different solutions. But This is a vascular surgeon in Michigan in private practice, and they implemented a night call 1 week at a time for the attendings. And they were really concerned about what would that do to their RVU production and how would that work with the workload. And they had no clinical responsibilities during the day. They did all the night call at night. They eliminated the need to having to operate post-call, and they found no change in productivity. They are happy with it and they've kept it. They had one surgeon who opted out of it, which I'm not exactly sure how they handled it. So not everybody in their group does it, but almost everybody does. It's not a solution for everybody. So I'm not saying this is how we ought to do it for everybody, but we need thoughtful solutions and out of the box solutions. So I know that there's some really smart people here at Stanford. So if you can figure out how to handle these night things, it would be really, really helpful. The other thing you can do is exercise. I joke about not doing vigorous exercise, but you do need to exercise. It does improve your mood. It increases your ability to handle stress, and it promotes high quality sleep and improves your fitness. But remember how I said that high work-related pain was associated with suicidal ideation and burnout and career dissatisfaction? Well, exercise can help with physical pain associated with the poor ergonomics in the operating room. So doing some strength training and taking care of your body so that your body can help you function longer in your career is really important. So if you think about it as a way to promote your longevity in your career, I don't know, that doesn't really help me like exercise anymore, but it does make me do it. The other thing we can do is practice mindfulness. Mindfulness is being present in the current moment, non-judgmentally. I stumbled across this book, 10% Happier by Dan Harris in an airport back when I still read books on paper. And it was a good book. And it described this guy's journey through his career and how mindfulness really helped him. But mindfulness has been studied in healthcare workers. And in a review of interventions that lasted 4 hours or less in healthcare workers, mindfulness practice, which is basically meditation, was showed to improve stress and anxiety, improve quality of life and satisfaction with life. And some studies had improvement in burnout symptoms, but not all studies. So that's something that I think definitely deserves further study. And finally, as surgeons, we tend not to take very much time off. This was a survey of the SBS membership, and 46% of patients take 3 weeks, or of surgeons take 3 weeks of vacation per less, and almost 20% take 2 weeks per year or less. So it can be hard to get time off. It can be hard to cover depending on your group and your practice. This can be difficult. But if you compare your days off to the average American worker, the average amount of PTO for the American worker is 10 days after the worker. And the average week is 41 hours per week. So if there's 110 weekend days in a year and you have 10 PTO days, that's 114 days or 16 weeks. So as a surgeon, if let's say you take 1 in 4 call, I've taken 1 in 4 call for basically most of my career. That's 78 weekend days that are off. If you add the 10 PTO days, which is essentially 2 weeks of vacation, that adds up to 88 days, which is 12 weeks. So you'd actually need to take 6 weeks of vacation to catch up to how much time off the average American worker has. So when you put them in that perspective, taking vacation is maybe something we ought to do. Approximately 45% of physicians work more than 60 hours a week compared with less than 10% of workers in other fields. So we work really hard, but and that's okay. But we need to make sure that we give ourselves a break to reset. So self-care is important, and really only you can take care of yourself. But we also need system solutions. We also need our work environment to help us support us. So how does that work? I mean, burnout really is an occupational hazard. Medical students enter school with higher wellness than their peers. And once they're in training, medical students, residents, and practicing physicians have a higher rate of burnout than the population. But personal resilience is really only 1/3 of the equation. So I've just spent a lot of time talking about what you can do to help your resilience and to help you function for a longer time in your career. But that's only 1/3 of the equation. We also need a culture that supports wellness, and we also need efficiency of practice. So how can organizations help? Well, the very first thing an organization can do is acknowledge and measure the problem. Organizations measure things that they find important, right? Everything they think is important, they measure. And then they try to improve, and then they follow that improvement and they track it, right? So if they're not measuring or tracking wellness, then that means that they're not finding it important. Most healthcare organizations, at least that I've, in my anecdotal investigations, are doing this now. But you also need leaders that value this. You need to have a culture of community at work and use incentives wisely, align values, and provide resources to facilitate all of this. So there's things that organizations can do to really sort of put their money where their mouth is. How does a culture of wellness develop? Well, you have the right leaders. You have the right leaders in place that value this. You want leaders who have the appropriate leadership traits, and you want to choose leaders in a way that is fair. You want to have leadership structures that include physicians. So in that situation, I'm talking mostly about hospital leadership structures. You really need to engage the physicians so that they can have some influence on how their work place functions. You want to make sure there's a fidelity to the mission and values, appeal to intrinsic motivations of the faculty and the providers, and communicate their values so that you can have value alignment. The best organizations have participative decision making, which include the perspective of frontline physicians. And I think this is really important. And that's so 3 years ago, 4 years ago now, I ran for and was elected chief of staff of my hospital, my main academic hospital. So that's a fairly big undertaking, but the chief of staff is responsible for running the medical executive committee, which really sort of is responsible for the quality of control, quality and safety of the patients and the care that's provided in the hospital. But the main purpose or the main value in my mind of that role was being at the table with the CEO of the hospital, the COO of the hospital, the vice presidents of the service lines, and the CMO, and really giving them the perspective of somebody who has provided care in their hospital, what that was like, what the challenges were. So as they were developing new programs and deciding how they were going to build their next building and build the new ORs and all of that stuff, that it can be done in a way that makes sense from the perspective of frontline physician. They don't always understand where their gaps in knowledge are. They don't, especially if they're not providers, they don't always understand what it's like to provide care. And they tend to view us as fairly interchangeable. They view, for instance, the operating rooms, one operating at one hospital is the same as an operating room at another hospital, but actually having to provide care at those two different places may be very, very different. And so they need that perspective. So hospital leadership structures need to include physicians, but to do that, physicians have to be willing to serve as hospital leaders, and they have to be supported in that role. And the value, as I said, is to represent the physician viewpoint to executives so that they can help them make the right decisions. So the more often frontline physicians can provide input to hospital leadership, the better we can influence the decisions that are made concerning our work environment. And that's really what we want, right? We want some control over how it is we do our work to make sure that it's efficient and valuable. These positions really need to be sought, and service in these positions needs to be supported. In addition, peer support is critical to navigate these challenges. Most of this work is really naturally organic support. This is where I talk about having really good partners. This is why it would be hard for me to move, because I've just got the best partners. I've got great peer support. I can bare my soul to them, and I'm not going to be judged. And the same is true back. This is probably something you guys have all heard about, and I don't want to belabor it, but there are ways to increase the collegiality and the peer support. We actually at Froedtert Hospital have a peer support network, mainly engaged to help people when they've had bad outcomes, getting the support that they need. So for the residents, I would say make sure when you're looking for jobs that you pick good partners. Make sure you are and feel valued. Make sure that there's the institutional culture where you join really values kindness, inclusiveness, and taking care of each other. It's important that we do that. If we don't take care of each other, no one else is going to help take care of us. In addition, appreciation is helpful. So this is, some people consider it bonuses and reimbursement, but just any appreciation. I had to go into work last Sunday. I was not on call. My laptop stopped working. So I had to review all the cases that Jason had put together for the boards that we gave on Monday and Tuesday. I hadn't reviewed them. So I had to go into the office, and I was like, mad that my laptop stopped working. I had to go into the office, and I show up in the office, and there on my desk is a plant and an appreciation card and a gift certificate for like $100 to one of our restaurants in town from the CMO. Thank you for everything you've done this year. Thank you so much for, we appreciate you as a leader at Froedtert Hospital. The $100 and a plant. And I felt so good. I felt so good about it. And it cost almost nothing. Totally unexpected, had no idea it was coming. And it just made my day. I was mad having to drive into work and have to do this work at work instead of being able to do it at home. And there's this beautiful gift. So sometimes it's the little things that really matter. obviously DEI is outside the scope of this talk. I don't have enough time and I'm not an expert on DEI, but if you don't have a climate that values and normalizes diversity, it's hard to be healthy. So we need to make sure that we're being inclusive and establishing goals and procedures to reduce the impact of implicit bias and achieve good, healthy DEI in our workplace. Efficiency in practice is the third limb of the third part of the triangle here. And so, I mean, it's hard to say, how do you make the EHR efficient? The people in Silicon Valley here probably are better at figuring out than I am. The EHR is horrible, in my opinion. It's just awful. There's some good things about it, but it takes up a lot of time and it's not great. It'd be good if we could improve EHR usability and interoperability. But really from the hospital system, this is the other thing I've really pushed. When they have to add tasks to the EHR, they can't just say, okay, here you go, doctor, you do all of this. You do these 150 clicks for every single patient. There's got to be some balance there. And they have to understand that these clicks take time and energy and really bear down on us. And so those conversations really need to be had. I don't have a great solution for this either. Happy to hear suggestions from people. But if there's any way to mitigate our documentation burden, we ought to try to advocate for that. Again, as things are being redesigned, engaging the frontline physicians in the clinical structures and processes. So I, in addition to being CMO, I also am the Senior Medical Director for Perioperative Services, which is really responsible for the operations in the operating room, the operational side of the operating room. So block time utilization, turnover time, on-time starts, case length accuracy, all of those things that help make our operating room function well. I'm sort of responsible for helping to improve all those things, as well as handling disruptive physicians and managing sort of the culture in the operating room. So it's a challenging job. It's a 50% protected time, which meant I had to give up a lot of my practice. That was something to consider, right? But I found it really valuable. They needed somebody who knew what it was like to operate in that operating room, who knew what the challenges were, who also could turn around and say, how do we constructively fix this? And it's a work in progress. It's not that I have all the answers, but it's a valuable thing. And I would say that if you're so inclined, seeking out positions like that where you can actually help improve the work environment for your colleagues is critical. So how do you influence your workplace? When your organization asks for your input, give it. Take the time. It takes time. You get these emails, you get surveys, whatever. Take the time, be thoughtful, give your input. If you don't speak up, they don't know that you're having trouble. If they're not asking for your input, find a constructive way to give it. If you have a problem, find out who the administrator in charge is. Find a constructive, engaged way to give it. Don't go mad. Don't go spewing things. Be thoughtful and be constructive. The only way you'll effectively influence your organization is if you can provide constructive, organized, objective feedback. The only way the organization can function well is if they actually seek that feedback and understand the problems that you're having or the barriers that you're having. And if so inclined, seek administrative leadership to help move things in the right direction. So healthy work cultures value physician leadership, careful use of RVU targets, physician administrator partnerships, multidisciplinary approach to team-based care, and the faculty with long tenure and low turnover. That's what you're looking for in a job. That's what you're looking for when you're looking for a job. So where are we with the health of surgery? I think we're in a good place. We have challenges, but we're recognizing them, and I think we're moving things in the right direction. If we can improve personal wellness and the idea of personal wellness and strategies around how to obtain that for ourselves, and if we can improve organizational culture, and from what I can tell from this organization, you guys have a pretty darn good culture, and I think our culture at the medical college is pretty good too. We all still have our challenges, but honestly, as I said, best partners in the world, it would be hard to recruit me away from there. If we can do those things, we will sustain our workforce and we will be able to improve our recruitment. We'll be able to have retention. The final piece of this, of course, is, as I said, we have an aging workforce. We need to find a way to continue to value and utilize the wisdom and judgment that has been gained throughout the years of people's career. And just the minute they can't take call anymore, not tossing them aside. It's hard to take call as you get older. You young people don't even realize it yet, but as you get older, you can't stay up all night and then operate and be effective all the next day. And certainly if you're in meetings all day, it's hard to be up all night and then be effective in a meeting. That's just really, really challenging. So as you kind of get up in life, doing those all night really like, especially if it's a dissection, which Jason knows I hate. He loves them, I hate them. I wish I could send them all to Jason. That's challenging to do as you get older, right? And so, but that doesn't mean that the older surgeon doesn't have value, can't provide value to the workplace. I was talking with John Harris yesterday, and I understand you guys have a program for, I forget what it was called, the FRIP program. Like, I need to learn more about that, because I think that's a great program where you have a decreased expectation for work, but for a couple of years you still get paid. And it's a transition to moving, a different phase in your career, or perhaps retirement. So I think those things, good solutions, creative solutions to how do we do that without pushing people out of the workforce is going to be really, really critical for especially general surgery, orthopedic surgery, and vascular surgery in the next 20 years. Talked about the compensation issue. What do we do about that? Well, the best way to do that is join an organization and donate to the PAC. And I'm not telling you what to do with your money, and I'm not supporting any single organization, and you don't have to do this if you don't want to, but it is the most effective way to make your money count. Alternatively, or in addition, contact your elected officials. This is most helpful with an organized campaign, but contact your elected officials, and if you have the opportunity, develop a relationship with them or their staff, more likely, to educate them around the challenges of being a physician. Work with your hospital. I was able to work on this group again through the SBS, so I've done a lot with the SBS, working on the value of a modern vascular surgeon. So we looked at the available literature on the financial impact of the hospital, and the FTE of a vascular surgeon contributes about $1.5 million to the bottom line of the hospital. So it's good to know that. It's good to have this information. This was a white paper basically written for local vascular surgeons to share with their hospital administrators and educate them about what we do and what value we provide. And it also highlights how to hire and retain. Most hospitals are having trouble hiring vascular surgeons because there just aren't that many of us. Have to work with your administrators. You look at this graph and it's just, they've exploded. There's more of them than they are of us, and you have to have a relationship with them. Take that time, develop that relationship. If you're in a position of leadership, you have to work with them. Get involved in hospital leadership. Then you can influence change. You can't influence change by just like bearing down and not saying anything or acting out. That's not a way to do it. You have to have these relationships. You need to be thoughtful and you need to be engaged. There's no use saying, if we're going to do our best, you have to succeed in doing what is necessary, right? We can't just say, well, we tried, right? We tried. That doesn't get us anywhere. So what's necessary? What's necessary is we need to celebrate wellness. We need to celebrate those that work well in teams. It's not so much about I'm famous, I'm great, I'm wonderful. I mean, that's all really nice, but when you're providing care to patients, it's teamwork, right? I'm useless without a hospital. I say that to people all the time. I can find a guy with a gunshot wound to the aorta on the street, and he's going to die if I'm the only one that's there. But you bring me to a hospital, you put me in a hybrid room or put me in an operating room, and I can do something about that. But I can't do it by myself. None of us work alone. We need to band together for meaningful regulatory change. And so there's been a lot of competition within the physician world. We compete with each other. That's sort of our nature. We really need to work on how do we band together and really work towards meaningful change. We need to strive to become and support those providers who are in local administrative leadership. We have to value that kind of leadership. We need to embrace and value surgeon wellness and satisfaction as a worthwhile goal. And I think really our culture in surgery has really moved to doing that. And we need to celebrate those groups and organizations that do this well. And we need to have and be colleagues to reach out to in times of distress. We need to understand that when somebody is acting out, that's almost always motivated by some other stressor in their life that has overwhelmed them. And you need to approach that situation from that viewpoint and figure out what's going on and help them handle that and get them the help they need so that they don't act out. That's a big part of what I do in my job, is helping to figure out those situations. If we can do all of these things, the world of surgery will be fine. We will be able to recruit and retain because we will be where people want to be, because we will be the kind of people and the kind of environments that people want to work in. And that's what we need to do in order to continue to provide high quality care to the population in the United States who's going to need us in the next 20 years. So with that, I'd like to thank you so much. This has been just an incredible honor. Thank you, Jason. I'm really grateful for the opportunity, and I'm happy to answer any questions.